We'll go ahead and get going while Nancy is connecting her audio. I just want to remind everybody that this is a discussion, not a seminar, so you can jump in and pose questions or comments at any point. You can turn your audio on and your video on and off as you wish. If it's loud, we go ahead and mute you. You can unmute yourself again then after that if you have another question and whatnot. So participation is completely voluntary. You can also submit your questions via the Q&A at the bottom of the chat, and we will get to those as quickly as possible. If you don't feel like you want to come on camera and ask a question, that's totally fine. Also, this is being recorded. So for future use of MOPA, the views and opinions expressed here are our own and do not necessarily represent the views of any of the Missouri Psychological Association. We are so happy to be here again for our monthly roundtable. Today, we are talking about the treatment of diabetes in primary care. So I'm going to kick it off by having the panelists introduce themselves. I'll start to my left, which is Kristen.
Afternoon, I am Kristen Thompson. I'm the System Director of Pediatric Integration at Burrell Behavioral Health. And this topic is just particularly interesting to me because during my fellowship, I worked in a diabetes clinic at Children's Mercy Hospital. Sorry, I'll kick it to Michaela.
Afternoon, everybody. I am Michaela Muehlbach, and I am the Deputy Chief Clinical Officer of Outpatient and Psychological Services at Compass Health Network. And I'm very excited about talking about this as so many of our clients have this kind of concern. And so looking forward to the discussion today, and always excited to hear questions and thoughts from the audience as well. So, Robin.
Last but not least. Hi, I'm Dr. Robin Lute. I'm a licensed clinical psychologist, currently working at Compass Healthcare. Again, just to echo the sentiments of my fellow panelists here, really enjoy these times when we have good conversation, and we really welcome questions, concerns, comments, as you are all also experts. And we know that diabetes is a huge contributor to so much morbidity and mortality currently in our country. So looking forward to another great hour.
And I'm Chelsea Gillum. I am the Assistant Director of Adult Integration at Burrell Behavioral Health. And I'm just going to start off today by giving some just baseline information on diabetes so we can go ahead and get that covered, fill any gaps that might exist. I would say a lot of you probably know this, so you need to zone out for a minute. That's perfectly fine too. But I think this is all important for building the case on why it's important that we are present and also treating diabetes in primary care. So diabetes itself is just a chronic disease characterized by elevated blood glucose levels. Basically, the pancreas in type 1 is just not making enough insulin or completely stops making insulin. And then that glucose remains in the bloodstream and doesn't get transferred to the cells. Those individuals with type 1 diabetes, they must take insulin to live. And this is mostly genetic, but there is some arguments that there are environmental factors early in life that also can contribute to diabetes as well. So both type 1 and type 2 are genetic and environmental and/or environmental. Type 2 is much more common and what we'll see a lot more in primary care. This is where insulin just becomes less effective in helping transport blood glucose to the cells. And if it's left untreated, then for several years, those cells progressively become more resistant to insulin. And the pancreas just continues to make more and more to try to keep up. Risk factors for type 2 is being overweight, gestational diabetes, a lack of physical activity, and being a member of certain races or ethnicities. Also taking atypical antipsychotic medications. So a lot of times we'll get those referrals when someone is just has insulin resistance, maybe they're pre-diabetic, is the referral and they need to work on some of these lifestyle changes. And so that might be when we get called in, or it may be when they've already got a diagnosis. We see that diabetes is increasing substantially. Between 1980 and 2011, the percentage of population diagnosed with diabetes increased 167% for those ages 44 and younger. 11.3% of the population in the US has diabetes, from ages 20 on, that is 26 million people. Another 35% have prediabetes. So this is incredibly prevalent, which is one of the reasons we want to make sure we did a roundtable on this, because the comorbidities that we see with diabetes in primary care are pretty substantial. Individuals with type 1 often come in with frequent urination, unusual thirst, extreme hunger, usual weight loss, extreme fatigue, and irritability. Type 2, you might see mild or no symptoms. They may have the symptoms I just mentioned. They may also have frequent infections, blurred vision, cuts and bruises that are slow to heal, tingling and numbness in hands and feet, reoccurring skin, gum, and bladder infections. And so the doctor's going to be asking those questions as well if they're pre-diabetic to see where they're at as they progress. And you might hear them use these things, saying, I'm having trouble just transitioning with this new diagnosis, and the physical ailments that kind of are the precursors and just part of that symptomology. So I think it's important we know what those are so that when they use that language, we know where that's coming from. There are, for kids, I think, Kristen, you're our kid person. It's similar to this, but there's other things that you would want to pay attention to specifically. Do you want to talk a little bit about that with children?
Particularly, so type 2 is very similar to adults. And although type 2 in particular in children is tied to diet and obesity. And it's something that, generally speaking, if a child has primary care, is on their radar. What can be really scary about type 1, which does most often present in childhood, is it often there are no warning signs until it's really upon you. And families find themselves, where their child is really sick. They've had an episode of diabetic ketoacidosis, which is DKA is the acronym for that. And that's essentially where their untreated diabetes, untreated because they didn't know about it, gets so severe that they just become really ill. They get hospitalized. They don't know what's going on. And then quickly, identified as being diabetic in the hospital. And so I think the important thing to know there is for families with type 1 diabetes, oftentimes this is a sudden and sometimes dramatic and traumatic revelation for the family. And that is where really behavioral health becomes very important there too, just dealing with a new diagnosis that has come on in a way that is surprising and sometimes scary. But in terms of the other thing I would add about just signs and symptoms, especially with little kids who can't communicate necessarily with you as well, some of the warning signs that are identifiable are increased thirst and hunger and increased urination. And there's actually, it seems like a really random symptom, but fruity smell on the breath. It's because of the sugar that builds up in the body, but it's really noticeable. And so that's oftentimes, when you have these other nondescript things like increased hunger, thirst, and urination, but then you have that unique symptom with that. That's one of the ways it gets identified.
If I may jump in for just a moment, we always give attention to cultural factors during these lunch and learns. And I just want to tag off of what Kristen is saying in terms of the diagnosis for people of color, for other minorities, tends to be delayed often, especially in childhood. Some studies would suggest this is implicit bias. Some studies will get a little more complex into health disparities in general. But there is certainly evidence to support that once the identification is made in children, they don't tend to receive, in children who are of the minority population, they don't tend to receive the same level of care, the same intensity of care. So just wanted to throw that in there as a basis for other comments that I will pepper through in terms of recognizing that as many people have this, it is definitely biased towards some minority populations as well.
I would say, like one of the clinics that I worked in, one of the things that we did is we put a pathway in specifically for anybody that was newly diagnosed with diabetes, because that transition from getting the diagnosis to all the changes that they need to make is pretty significant. And I was going to ask Michaela or Robin, either of you kind of at Compass, how is it that you guys go about treating diabetes, once you get those referrals, whether it's from a pathway that's already in place, maybe it's a comorbidity that you're seeing, but you're realizing they're having trouble with diabetes specifically. What do you do?
Oftentimes, it probably isn't surprising to anyone on this call that we oftentimes see that in the primary care setting. And so our BHCs are just totally integral to that particular issue. And so typically the BHCs will kind of capture that referral. They'll start working on behavioral management, education to the parent and or the client, and also working alongside them to, if they need extra support. Like you said, it's such an impactful diagnosis that changes so many parts of their lives, that should they require more kind of in-depth or intensive supports that maybe we can't provide right there as a BHC, we can make sure that our outpatient team wraps our arms around them with ongoing therapy or case management, maybe even psychiatry if that's not indicated. I think that I'm always interested in hearing about what the BHCs that we have on these calls have to say as well. But I think one of the most pivotal things that can be so wonderful about having the BHC is that they are kind of the link oftentimes between primary care and outpatient. And I think that's just the most important thing is we may not be able to manage everything right there, but we can definitely link you with people who can. But I don't know if others have any other thoughts, but that's kind of the high overarching view of what we would do.
You kind of hinted at this, Michaela, but just to highlight that there are a lot of individuals, and somebody may speak to this more specifically, the overlap, the incidence of individuals who have diabetes who also have depression, whether it's sort of what we would call a reactive depression to all of the changes that need to be made, or an endogenous type depression because of all of the hormonal changes and medications. The prevalence of depression is extraordinarily high in individuals with diabetes. And so you were talking about wraparound care, even psychiatric services. Certainly we do see that is often, again, we're playing maybe a bridge role to getting individuals to some more intensive care or a different type of care. There's also that version of very real diabetic burnout where an individual just every choice every day is impacted. This disease, it's essential to be hyper vigilant almost with your lifestyle. And so that can get really old, for lack of a better word, for lots of people.
Yeah. And one thing, Robin, you kind of triggered a thought in my mind too, which is it kind of harkens back to our discussion a few months ago about eating behavior, and that oftentimes when individuals do reach a point, like a tipping point, so to speak, that there are oftentimes emotional and or behavioral health reasons why individuals reach that tipping point. And so helping with that kind of underlying reason of what are we using food for, and kind of understanding that perspective a little bit better can be really valuable. And sometimes that can be done in the BHC setting in primary care, and sometimes that needs more intensive treatment.
Robin, you mentioned that burnout factor, and it reminded me that a few times when I was treating individuals with diabetes and they were not making the changes that was recommended of them, which is how I got that referral. A lot of them talked about how this diagnosis came off of something large in their life. So like they already just quit smoking, or they just got they are in cancer treatment, they just finished that. It would be something big. And then they get this kind of diabetes diagnosis that requires substantial changes in their life. And they would say, I can't do one more thing. And so I think timing is huge on this. Sometimes, I think they get a lot of information on these are the things that you need to do. Now go do them. And there's no thought to why that might be really difficult, which is the beauty of why we're there, right? Like we get to ask all those questions and kind of dive into that. But you're right, and Michaela hit on this, like there are lots of reasons individuals might not be engaging in those services and doing the things that they're being asked to do. As with anything that we get a referral for. And then with diabetes, you mentioned the high rates of diabetes. Actually, individuals with diabetes have a doubled risk of depression, literally doubled. So pretty significant. And what we see overlap with depression. We see overlap with anxiety as well. There's an increased risk if you have diabetes and having anxiety. Also schizophrenia, higher rates for type 2 diabetes. You think about mental illness though, generally individuals are they're not going to at the same rate engage in their care. We're just not, we see that across the board. And so anytime we have this comorbidity of diabetes or some other chronic disease and we have mental illness on top of that, their risk increases substantially. Now determining whether or not we treat, which one we treat first, that's the tricky part is BHCs. Any thoughts on that?
I just want to piggyback off your comments about burnout. And so like I've been doing this and I'm burnt out, or I just can't do this. And that's a huge factor for kids and adolescents too. No, you don't have diabetes. That just totally gets in the way of everything, right? And think about how limiting that is for a child, really at any stage in development. It impacts everything. It impacts sports. It impacts, can I go on a sleepover? It impacts, can I eat the same things as my peers at lunch? It impacts, it's Johnny's birthday and they brought cupcakes. And can I have this? How do I have this? Do I have to have this differently? It just makes you different. And kids don't want to be different. And it can be so difficult, especially as a child. Your developmental perspective is that I'm invincible, this can't hurt me, and all the consequences of diabetes are really far away. So it can be really difficult to engage kids around treatment and get them to take it seriously, for lack of a better way to say it, because there's just so many barriers. So a lot of times we'll have kids who maybe they do okay in the home setting because you have the parent really managing that. But when they have a layer of independence at, practice and school and whatever, where they have a helper there, the nurse or whoever to help them, but it depends on the child engaging with that helper, things really fall apart because it requires that child's engagement rather than somebody coming to them. So that's really hard. And the other thing that's really hard, thinking from the diversity lens, Robin, not every family has access, not just to care, but to healthy food, to exercise. Diabetes is really complicated. What's a carb? What counts as a carb? How do you count those? How do you track those? Not everybody has the executive functioning skills, let alone access to, diet and exercise tools. It's really complicated. It's a lot to keep track of. So that too, you think of kids who developmentally may not have those things, or just families who are stretched and exhausted and tapped out and don't have a lot of resources. And then you layer this on and it can be incredibly difficult. Even if you get the diabetic educator in and the dietitian and you teach the things, actually implementing those is really behavioral. And sometimes it takes someone like a BHC, someone from a behavioral health background who can break down what the actual structural barriers are to help them get to a place where they can actually apply the education that maybe the diabetes educator has given. Sorry, that's a lot. I had a lot of things that I wanted to comment on.
I think it's great. You apologize, and the only reason I'd say apologize is because it did the same thing to my brain, where I want to comment on 15 different parts of what we're currently discussing. You just picking that diversity piece for just a moment. You mentioned access to food. Often when we're talking about, we all know the overlap, the overrepresentation of, indigenous cultures, people of color who are overly represented in terms of poverty levels, and, areas like food deserts, where even if a person learns choices and learns how to make healthy choices, it may simply not be possible for somebody to drive to go get the appropriate kinds of foods if they're not available in their neighborhood, which does tend to happen again in lower income neighborhoods for sure. You know, diabetes prognosis can be pretty well predicted by zip code, which is a really interesting and almost frightening thought that outcomes almost follow a linear correlation with zip code. So to say that, you know, the setting matters in this case is an understatement. You know, in addition, we haven't quite hit on technology yet, but children of color are not going to receive as much use of insulin pumps. They're not going to be offered the treatments that tend to make life just a little bit easier in terms of managing that glucose. Because the other piece of that, Kristen, you said once people learn what are the macros and what are the carbs, and it's still changing. It's not like you can learn a formula and then that's what you do every day if your stress level goes up. And again, we know, you know, people of color who sleep at night, their cortisol levels don't drop the same way as white individuals will say. So it's, again, sorry, as Kristen said, but it just made my mind go in so many different directions. This topic is just so complex from diagnosis to prognosis. There are just so many factors that matter.
And absolutely, I echo everything that others have said. And the other piece to this is systematically working within the team. You know, the joy of having a large system is that you have so many other team members, and the downside of that is that it almost becomes a little overwhelming to know whose role is what and who should be doing what piece. And so we often recommend, I always feel a little bad for our BHCs because we're always saying that they're a great pivot person. They're kind of traffic cops as well. And a large part of what the BHCs do in addition is to really help what was just mentioned, you know, talking to the providers about, you know, these individuals have a higher likelihood of having co-occurring mental health issues that we also need to address. And so being able to remind the providers and then turn around and support them with those pieces is so invaluable, as well as letting the entire system kind of be aware of what gaps in care do we have for individuals who are presenting to our primary care providers and clinics, and where does the administrative leadership kind of have the opportunity to kind of step in and provide the resources that are needed. Maybe it's a grant to purchase those glucose testing kits. You know, there's a lot of different, I think, spaces that systematically and kind of provider education that there's a lot of opportunities there.
So when you say systems, it always makes me think of the family system too. And I know we always talk to parents about interacting with your child with this new diagnosis and how is the family going to change? And those kind of conversations are fabulous, but I think sometimes where, and I'm guilty of it too, where we miss the mark is we forget about talking with the parents about the siblings. Because now we've got a bunch of other kids here who are going to have changes in their world, changes in the food that's brought into the home, changes in what snacks are available and what aren't available anymore. And can I eat this in front of my brother or my sister now? And those kind of conversations are huge because it's not just the kiddo that's experiencing the change, whole system.
Thank you, Caitlin. Yes, 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 yes. And how true of this is this of so many kinds of things, right? You have a member of a family system who has X new diagnosis and it requires X things of them. Whether or not the family gets on board is going to have an impact either way, right? And you have to decide as a family how you're going to do this. If the family doesn't get on board, then that individual feels isolated and alone, and they have to follow all these rules that nobody else has to follow. And that's really hard. I've seen that. And then I've also seen how, you know, the parents say, okay, fine, the whole family, we're all in, you know, we're not going to do this anymore or that anymore, and we're support you and we're together. And then everybody's struggling through a lot of change together, and there's unity in that, and there's a lot of solidarity, but it's really hard. And then you have to deal with the siblings frustration, and it's just really complicated. And to neglect the impact this is going to have on the whole entire system, absolutely, Caitlin, to use your words, misses the mark. And if you're not preparing the whole system to be thoughtful about what they're going to do, how they're going to do it, and what impacts those are going to have, you're going to miss. So thank you, because that is absolutely our role. And that is a place where we have something unique to offer, because that goes above and beyond the carb counts.
That's a really good point. And I just want to echo that, but that also occurs in an internal med with elderly as well, is that they have oftentimes lots of like gender stereotype behaviors. So we have a lot of women cooking, and they've cooked the entire relationship. And now one person has diabetes, sometimes her. But this means that the entire family or the spouse is going to eat differently. And we see a ton of resistance after 60 years of making that change and adjustment, to the point where they just say, it doesn't matter. It doesn't matter. I'm not going to make that change. Even we see a lot of domestic violence in that population that we don't usually talk about that, but a lot of that actually occurs around food changes. I've heard many stories of people throwing plates against walls and things like that when they were served something healthy or different than what was typical. And I think we need to talk about that more, about how that system needs to make that adjustment and how the family needs to be part. That some of that we need some changes with billing insurance companies so that we can actually pull the family in and have those discussions. But that's for another time. But we absolutely need to make sure that we are doing those things.
It's really interesting to hear. I mean, having worked with diabetes in different ways over, gosh, almost 2 decades, I had no idea that things would get that intense. I almost feel badly that I made sort of a lighthearted remark over here, give me my meat and potatoes in the chat, which is kind of the conversations that I do hear, like you said, especially if the woman's diagnosed and she's doing the cooking, although now it makes me feel a little bit like I shouldn't have been silly or lighthearted about it when it's getting to a domestic, an interpersonal violence level. That's really profound.
I wish I was just being dramatic for like sake of remembering information or something, but the amount of conversations that we have about domestic violence in internal medicine is pretty heavy. It's on a daily basis. That's one of the main things that we deal with. So any changes, whether it's exercise and leaving the home or joining a gym, whether it's food changes, whether it's just attending your medical appointments or seeing a behavioral health provider, all those things really trigger that common theme that we're seeing in internal med, which is that we have kind of an angry system.
Yeah, many times you have the person who is the primary cook making those changes, and the other person who is the diabetic is refusing to do it, or looks like they're complying, and then there's fast food wrappers in the car. And if they're in a work setting, there's other kinds of things. And so there's a lot of issues between the spouses. And the other thing, for those of you who deal with kids, it's not only the nuclear family. I've had grandparents want to blow up the system because, oh, you poor thing, here, have a gumdrop or have this, and not being on board with what needs to happen, because particularly if it's a younger child, is somehow seen as deprived. And how could it possibly be Halloween without the real trick-or-treat candies? And yes, they can have some of them, but they can't OD on them. And then you have to know how to adjust, And the other thing that I've seen is that parents who get this diagnosis for kids, and they are like a super control freak, and they're losing their shit, and the kid is fine. The parent is nuts. I've seen in meetings that involve general education for the public, parents absolutely lose their shit, because their job is to get every note in every conference and write it all down and go home. And I think that the hidden secret is you can do the appropriate thing, the same thing day after day, and get different results. This disease is a weird one. you can do everything that you need to do, and you get an F on your report card when you walk into your primary care docs or pediatricians, and your HbA1c is not whatever it needs to be. And it doesn't mean you haven't been doing everything, but if you're just doing, blood sugar checks 4 times a day, you're not noticing that someone's got a 300 blood sugar all night long. And again, technology is really moving, and some people have access to it. Not continuous glucose monitors are now starting to be the standard, and not every insurance company is going to go along with that. The supplies are very expensive, and it's a challenge, and to use that. And also it's a control thing, because there are parents now who on their Apple Watch have the Dexcom reading, so they're in touch with the school, the kid, and another spouse, because you can follow this kid, which has positive, but also can be a little too much. Big brother and big sister, mom's always watching and knowing what I'm doing. So there's a whole lot of new stuff coming down the pike, which is great, but it also adds that complicated layer.
Yes. Oh man, our round table is activated.
Yeah.
Those are
Hey,
just
listen, I mean, I don't think endocrinologists get it. I'm not kidding. I've done this work for a bazillion years, and things really changed when things started to happen in my family. And I felt like, boy, I'd like to go back and apologize to some of the families and some of the people I've worked with over the year. I'm a much better psychologist for someone with type 1 or type 2 diabetes, particularly type 1, than I used to be. And it's because I have personal knowledge and I understand stuff that I thought I understood that I didn't understand, but now I get. And I think that's always, that's always tricky. But I'm amazed at the resources that parents initially use, and a lot of other adult diabetics now that are out there that are you can access at Zoom meetings, you can access on websites and all, and they're on the cutting edge of what's going on, who's doing it, and how it works. By the time it gets to their endocrinologist's office, it takes a while. And if they've seen 25 patients that day, they're lucky they remember their name, let alone say, oh, by the way, you might be helped with X, Y, or Z. It depends on what drug rep just walked in their office as to what they're pushing.
yes to all of that. And I really want to pause for a second on that point of their team may not know that their endocrinologist or their their nurse educator, they may be missing something. And I, as the BHC, I mean, it sounds like you're wonderfully educated, and there are many people who have lived experience of this, but most behavioral health providers know very little about it. And so how do you walk that line? And how do we avoid saying, well, if you would just do what they told you? That's the hardest part, because we don't want to be another part of this system where we're just saying, well, how do I help you do what they told you to do? Because that's just so not it sometimes. Sometimes there's just a missing piece, and nobody's quite put their finger on it through no intention. It's just missing. And how do we empower our clients to work with their team, or to try and uncover something when there is something missing? It requires us to be communicative with our team and to have a working knowledge of diabetes without overstepping. It's really tricky. And so I think that's just such an important piece you highlight.
Well, I think besides doing a hell of a lot of CUs by Zoom in the last year and a half now, that's one of the things I've been able to do, is access some conferences that I had thought about going to, but I didn't have the time, but I could do it, and to see kind of what's out there. But for many of us, that's not the only area we work in. It's just that, okay, I can pay more attention to this one. And it really, it really varies. And it varies on what part in the progression they are in terms of how old or new the diagnosis is. And then you also add the whole adolescent piece. What better to fight about with mom and dad? You want to control me? Watch what I can do. I'm going to do this, this, and this, or not do this, this, and this, and watch my parent get even crazier trying to control me.
And and then how do you, so you have all of that dynamic happening, right? And you also know that your child's about to leave your house and they need to manage this on their own. And how do you help families navigate that? Because it is so hard, especially when you have the parent who is extremely knowledgeable and well informed by their Apple Watch. Because even if you take adolescent rebellion out of the equation and you have a child who's really trying to take responsibility, what's the parent do when they see that they've done it wrong? They're
Well,
getting notifications.
and again, it's the right and wrong, but the irony of the whole thing, it's because of one of these parents that one of these cutting edge systems has been developed, and it's not FDA approved, but it's just about there on the artificial pancreas, because this engineer had a son who was diagnosed as a type 1 diabetic, and he was bound and determined to figure out something that was going to get close to an artificial pancreas by the time this kid was ready to go to college. And I believe he's now a freshman or sophomore at college. But this was a BU project, and he hooked up with the diabetes people at BU. And, they've developed the system. And it's got both glucagon and insulin in it, so it can do a variety of things. But I mean, and the same thing, the whole thing with the watch, before there was the Apple Watch, I'm thinking it was 6 or 8 years ago, there was a website called We Can't Wait. And I had a parent who had some kind of throwaway cell phone attached to a Dexcom that attached then to her special, she had to have a special kind of watch, and parents figured out, and her husband could do this because he was an engineer and knew how to jerry-rig the different parts that you get at Radio Shack. Now it's more part of like the Dexcom system. But I mean, that was driving a lot of it, because we need to know more. But even those systems, it's not set and forget it. You have to interact with it and understand how it works. And I think there's a piece that many people don't know. It's not only the carbs, but fat and carbs, or protein and carbs, or fat, change all those parameters. So there's now some work looking at how do you change the bolus, the amount of insulin you give to a type 1, if it's not only a high fat meal and a high carb meal, but based on the protein and things like that. So again, all these factors, and some people talk about it, some people don't talk about it. And sometimes you can tease out and find information, and sometimes people talk about it and you can't find the source. So it kind of varies. But I think where you have to meet your people and your families is where they're at. So many ways you're being told you're doing something wrong because a lab test tells you, and there's nothing more aggravating than that. When you've done what you need to do and you're having someone kind of be a little judgy with you.
I think it's important to remember that sometimes a referral to us feels like judgment. So we
Oh,
do
yeah.
that immediately.
Oh yeah, when you get their referral from well, I worked in a different setting. I work in private practice, but even as an intern 100 years ago, when you get their referral from a med-surg floor, you're in for a ration of shit, because you're walking into a room where they don't want you there, and the doctor very often has not prepared them that you're coming, but they're so frustrated they don't know what to do, and the patient's first response is, so they think I'm crazy? No. So we've come a long way since then with integrated teams, which is great. Yeah.
Huge part of that acceptance, I think, Elizabeth, is how the physician team introduces the BHC themselves and the role of the BHC. It's very important for us to have all of us to have our scripts in terms of how we introduce ourselves and how we kind of interact and introduce one another. So I agree with you. The progress there is really substantial, that we're able to work together quite a bit more effectively. And I don't know if others who are working actively with physician teams as BHCs or as psychologists, counselors, have thoughts or ideas about how we best do that, how we, what makes us successful in terms of introducing our role.
So I can give my 2 cents on that. I think one of the things, just a BHC staple, is I'm part of this team, and trying to coach the providers to introduce you as a team member and really focus on the primary care setting, and get away from I'm the therapist. So I'm part of this team. I come in and meet with families when they're struggling to make progress, with X, fill in the blank. And I usually just have a little bit more time to sit down and kind of help a family break apart the issue. So sometimes I introduce myself, especially with these medical components, as I'm kind of the detective or information gatherer, investigator. I can come in and really break it down with you and then work between you and the team to try and come up with some solutions, because I've got time and we can really just sit down here and talk through it. So I don't know, I think that feels a little bit less, I'm going to come in and deal with the behavioral health part.
I have a question about something Noah wrote about thin privilege. Are you saying that a patient suggested that you couldn't get it because you're thin and you have no idea what it's like to be me? It's in the chat thing.
Yes, essentially that's the implication. Yeah, it was an interesting conversation.
Yeah, well, that's one more way to say get off my ass, because you can't understand it. But the problem is, it's like having a size 3 nutritionist talk to you about not using certain products, and you're thinking, yeah, you're a little chicky in a tiny little outfit, But the reality is, we don't know what's going on in that healthcare provider's life, yeah.
Interesting how sometimes we are judged and having to deal with that kind of transference, just to use the broadest term.
Don't you know we have the perfect families and the perfect kids and the perfect everything, because we're like,
well, I'm coming to your house, I think.
No, I don't think so.
But I mean, it's somewhat of a, I don't know, like a, I don't know what the word is. I have not had lunch yet, sidebar. So struggling with word retrieval, hardcore. And so I think that is a space of diversity, though. Like, the assumption is that you can't have diabetes if you're thin. I think that is another space, right? Or that you must not struggle with eating if you're thin.
Very nice.
And also, you can't, only kids get type 1 diabetes, and it is the majority, but the reality is that there are people in their 20s, 30s, and older who, out of the clear blue with no family history, can get type 1 diabetes. And what the feeling is it often happens in the spring. Perhaps there's a virus or a flu or something that starts to attack the pancreas. But again, endocrinologists make the assumption, oh, you're a chub, you must be type 2. And sometimes as a patient, the patient has to say, give me the magic test. There's a couple tests to see if there's any pancreatic action. Surprise, surprise, this is a whole different thing. It's a whole different class of medicines and treatment you need, not the typical go see the nutritionist and lose weight nonsense. So that will vary. I have a question about those of you who live out more in the rural areas, because many families are, we eat certain ways and we eat certain foods, and this is the way we've always done it. And it's hard. Is there any resistance to changing some of those things?
100% say that in rural areas that there are stapled meals, and I think we see a lot of that. I was thinking that earlier, we were talking about individuals struggling with that transition. Sometimes it's really cultural for rural areas or the Ozarks, for where we live, that there are just staple meals and that things pretty much stay the same. Change is difficult for Ozarkians in general, in my opinion. And so that's just another one of those things. I think that there's a cultural component to that. And also, I just want to say before, I want to talk about Noah's comment here just real quick. My thought on when people bring up, you can't understand because of this reason, the underlying emotion of that is that they feel incredibly misunderstood and unheard. And so I think it's important that we hear those things, that it doesn't actually become about us at any point, that it is what is the feeling that's behind that, and then how do I reflect that back to them. So I think that way you don't get caught up in like the nuances of, is it true or not. It doesn't matter. We all know that that's not an accurate statement. You don't have to have a broken car to be a mechanic and those types of things. So, but you do have to understand what the emotion is behind it. That's a good focus. Any other thoughts on rural care? Because I want to make sure we hit that other than what I just said.
Did you say rural aspects?
Yeah.
Yeah, so I've worked with, in Kansas City as a BHC, I worked with a lot of Latinx or Hispanic individuals. And we would ask them as part of a program to adjust their diet. And of course, their diets can be high in carbs, like simple carbs specifically. And that can be a challenge, like tortillas, rice, things like that. And so we were asking them to give up a lot. And so we had to navigate that aspect of their culture and their identity in like a respectful, tactful way.
I think when I also think of rural, I think of health literacy. Where access to healthcare is low, health literacy is also low. And you think about extended family involvement, which is important. And you think about family gatherings. How much pressure are you getting at a family gathering where, now you have this big extended thing where something has to change because of this one person who, why you listen to your doctor about that anyway? Or like, that's not that big of a deal. Or, your grandma raised me on fill in the blank. And there's this push against the change that impacts the system and the status quo. And part of it is because of mistrust of the healthcare system and difficulty changing generational patterns. And it's wrapped up with low health literacy and a whole big complicated mess of things that are part of the rural culture.
That was well said.
Oh, and don't forget, we have the holidays coming. It's the holidays. It just wouldn't be the holidays unless you ate blah, 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 blah. Oh, just this one time, it'll be fine. Oh, so we have to take you to the ER the next day because you're in a coma. Sure. No, I'm being a smart ass, but it's not dissimilar to someone who is doing other health kind of things to lose weight or has a cardiac or kidney issues or whatever. And everyone wants to convince them, oh, it's okay, just this once. And so basically they're being told, well, it really doesn't. You and your health issue don't matter.
Right.
Americans celebrate with food. We do.
I don't think we're the only culture that does that.
Well, we're so heavy on unhealthy foods, unfortunately. It is, I think, part of rural culture as well as the broader American culture. I mean, certainly we see pockets. I lived for a long time in California, and the culture was very different with respect to the function, as Michaela mentioned earlier, of food and what food is about. And you're right, it is very common to celebrate with food. It's just when we have supersize the supersize and sort of excess, and it's so easy. And that's another piece of where certain populations will struggle. Kristen mentioned access to healthcare, and again, access to healthy food or the ability to even afford healthy food if it is available. It's just a challenge for a lot of different areas. This is heavily cultural dependent. It makes me think so much about, could we think of a diagnosis or a disease process that more specifically benefits from the biopsychosocial sort of spiritual model? I mean, it's just so dialectic in terms of all of the complexities that are interacting, and we really have to have a broad conceptualization of how to be helpful.
So on that note, then, a lot of what we do as a BHC is diet changes and working to motivate an individual to make those changes in ways that they haven't gotten before, by identifying those barriers and kind of busting through those, talking about underlying issues that might create those barriers. So diet, exercise is another big piece of this. Actually doing your blood sugar testing is a piece of this. Foot care may be a piece of this. Stopping smoking is a piece of this. So that's kind of what encapsulates as far as adults on how we treat them and how we focus, but ultimately give them a different experience, because I'm guessing they came to you because it's not what they've tried before has not been successful. What people have told them has not been helpful. And so like Kristen said earlier, we have to give them a different experience. We have to do something different than what they've had. So anything that I'm missing from that on kind of generally what our treatment focuses on, or any other thoughts?
I think one thing we just haven't hit on at all is that when blood sugar rises and falls, that can also contribute to mood changes. And so sometimes, even if we're not talking about a standalone diagnosis of anxiety, depression, with kids' oppositionality, irritability is a big part of blood glucose fluctuation. So I think sometimes, even if you don't have a secondary or primary behavioral health diagnosis, you're still getting lots of psychological and mood impacts of blood sugar. And I think that's an important thing for BHCs to be aware of, because we still have a role in helping families navigate that and helping use mood changes, not just as sometimes it's a warning sign that you need to check your blood sugar or something's going on. I'm feeling irritable or tired or lethargic or anxious. And that's a sign, but also, I am going to experience that, and how do I manage that?
But I think educating families on how to do that appropriately, because the problem is, if you want to see a kid or an adolescent or even adult get angry when a family member turns to them and says, you need to check your blood sugar, and it's like, no, we're having this argument. I don't need to check my blood, whatever. The point is, then it's another thing to be angry and upset about, because you're trying to control me. And the family member is trying to give them a piece of information that they're concerned about this. And again, how do you get the kid in there so that, is there something that the kid and the parent can work out so that mom or dad can say something that lets them know maybe they need to do something without actually saying, you need to check your blood sugar.
Yes. And in fact,
well, when was the last time you checked your blood sugar?
Yes.
Those are fighting words you throw
they
down.
Are. And even something so subtle as I worked with families where they have a code word instead, because otherwise you need to check your blood sugar is code for, like, you woke up on the wrong side of the bed. It is.
Have you taken your meds today?
Right. Yeah. But if you can just, if you just have a subtle, quiet code word, ladybug, it's like a cue of like, oh, but it's not leveraged as an assault. And I think that's such an important thing, where the intention may be the same, but the way it's received is so different.
Does anybody else feel like we need a part 2, 3, 4, and 5 of diabetic
10,
care?
20, 30, 40, 50.
Yeah.
Well, but I think even as psychologists or mental health folks who work in this area, many of our colleagues, oh, you do that stuff. I mean, I've been doing healthcare stuff when people, for so many years, it was when people said, you do what? Now it's got legit, now it's healthcare, now it's this, people are integrated into systems. Many more mental health professionals are educated in all kinds of chronic health issues that maybe were not before. But I think a lot of our colleagues still don't quite get it.
Mm-hmm. Elizabeth, that's a good point, because I always want to make sure I say this, that even if you're not in integrated care, these things are so important that you know them. They're still walking in your office. And so even for the individuals who aren't working necessarily in healthcare or physically located there, these trainings are great for everybody.
Mm-hmm. And that actually also, Elizabeth, made me think about Chelsea's initial question at the beginning to me and Robin about, like, system-wide, what do we do? And so it's not just about, like, us educating in the primary care space, it's also about us educating in the outpatient space of what kind of things to maybe look for if you have a patient that might trigger a recommendation or a referral to primary care. I noticed that there's a lot of us on this that are having a lot of dialogue in the chat, and I just really appreciate and enjoy hearing all that information. And I think that keep talking, I guess, is my point. Like, we keep talking to each other, we keep talking to our colleagues, and keep talking to the people that we work with. And I think that we just continue to learn from one another, and system-wide, that eventually we'll all kind of know. I say it all the time, but everybody can agree that integration is such a great idea. Oftentimes it's hard to figure out how to do that. Who do I go to? Where do I go? What do I ask? And so just ask somebody.
I have a question. Someone mentioned the Box diabetes distress scale. Where does one get that?
It's online. You can get online. I think it's also in the purple book, but it's probably updated. I don't know. I don't really know where I got it, but I have it and I used it. I think it's online.
Okay.
But
Right.
yes, you look up
But you-
diabetes stress scale. It's got lots of good questions about how they feel, which is what I really like about it, because then you can kind of gauge whether or not how fearful they are and how that changes as you treat them.
Chelsea, it's available online.
Thank you, Justin.
I think
Great.
I just
You're
posted
welcome.
it in the chat.
Any final thoughts here as we approach our 4 minutes?
I guess I just want to echo Michaela and what everybody's saying here is just keep asking questions and don't, I feel like this is true of everything we talk about in these roundtables, but don't feel like you can't intervene in that space. Yes, it's important to stay in your lane. Yes, it's important to educate yourself about the presenting problem, whatever it is. But this is just all human behavior, and this is our space too. And there's a lot we can do to help. And if you're motivated to learn and ask questions and be vulnerable, and even say to a patient, you know, oh, I don't know as much about that. Can you tell me some more? And then you Google it before the next time you see them so you can fill in the gaps. But just be curious, just like anything else, because none of these medical things should feel scary or off limits, because there's a lot of work to do.
You know, I was going to jump in and say something very similar to that, Kristen. You know, in the grand scheme of things, we have to remember that you know, we don't dehumanize those that are going through this. That diabetes, though it's a really relevant and prevalent type of thing to go through, I think we have a tendency at times to find ourselves in a position where we focus more on the disease, not the person. And you know, diabetes is such a challenging thing to work through. It's easy to manage in theory, but it is such an impact on the livelihood of all people around, not only themselves, but as we said, those that they interact with. So as we learn with one another and grow with one another, it's just trying to remember too that the patient is going through a lot of transitions, and unfortunately it's going to impact so many different lives around that individual as well. One of the best things we could possibly do is make sure that we have open ears, open eyes to see, hear, and do the best we can to understand where they are, try to understand best the familial area they're in, if they have it, what type of support group they have. We also, I would say too, need to understand that we may be the only support system that some of these folks may have, especially from those that are from a disenfranchised background or just a very solitary background. No, they're going to be fighting this alone. Now they have to change the entirety of their lives. They've reached out because they've run through these states, and we may be that last person that they can look to help, you know, guide them through this path.
Well, I think also we have to see them as a person with diabetes, not a diabetic, because, you know, if someone's tall or short, we don't call them short or tall. We call them a person who is short or tall. But also, that's just one of the things they're dealing with in the life. And that might seem very minor, but it's very important because they are not 100% diabetic. They're a mother, they're a father, they're a child, they're an athlete, they're this. And there are ways to do just about anything you want, but you just have to think about how you might go about it. And that, I think, can be one of our jobs, because we can be the one that says, sure, why not? Go for it. Let's think about how you go and do that.
And you have a better ending than Kristen and Justin and Elizabeth just then. I'm going to absolutely stop that there, because that was a perfect 3-part ending to this roundtable.
Only if you guys call me Liz from now on. I don't go by
Okay,
Elizabeth.
Liz.
Okay.
Just before you go, I'm going to give you the upcoming webinars that we have. On October 15th, we have History and Best Practices of Police Candidate Assessment and Psychology. November 13th, Critical Race Theory. What is it? What it ain't? And everything in between. November 19th, Forensic Psychology and Overview. You can learn more about all of these at mopaonline.org/MOPA Learning. November 4th is our next roundtable. It actually has a 1-hour free CE for that for all MOPA members. So if you want to access any of the old archives, you can go to mopaonline.org, and all the other webinars are there as well. Thank you all for being here. We will see you next month.
Thank you.
Thanks, everybody.
Bye-bye.
Bye.